The conventional approach to sarcoidosis, and also some twists on the conventional treatments of sarcoidosis based on the manifestations of your disease. You may not be able to tolerate all of it. You may not be able to tolerate that much better than you may not be able to tolerate some of the medications depending on which organs are involved. So, there we go. So here's kind of the typical algorithm that most sarcoidosis specialists would agree with. We tend to first try to figure out if there's any reason to treat. I think everybody in this room is falling into a category where they need a treatment, so I won't dwell on that, but I do want to make a point that we don't just treat everybody that comes down the road. And as Dr. Judson said, sometimes the granulomas are there, but they're not active. People can go into a remission of sorts where biologically, even though the granulomas are present, like you have big lymph nodes, but you feel fine. I mean, people don't even know that they have the disease. They're not fatigued, and none of those things. But other times, that same person, without much change in their X-ray or other manifestations, may find that they're very symptomatic, with all these other things. So you have to decide whether or not you're going to treat, and then once you commit to treatment, you try to figure out what can I do to offer my patient the most benefit and the least harm. That's always the equation that we have to use. And so that's why a lot of times my patients will, I'll try hydroxychloroquine, for instance, in somebody who has minor aches and pains and some, but no vital organ impairment. Hydroxychloroquine is actually a pretty safe medication. There's not too many side effects. You have to have your eyes examined frequently because you can get changes in your color vision. If you catch them early, if you stop the drug, they'll go away. It's not a problem, but you just have to, you can't go on. I remember one patient coming in and I told her, you might have to watch your eyes. She missed her eye appointment, saw me, a month later, and I said, well, have you been getting your eye appointment? She goes, no, but I said, do you have any visual changes? Yeah, she says, well, I was at a birthday party and I was wondering why the cake was green and everybody else saw that it was white. That's a problem. So it doesn't happen that often, but when it does, you got to stop the medication. But otherwise, I would say more than 50% of the time, those people that have just generalized aches and pains, arthritic pains, those kind of things, hydroxychloroquine helps. It's been reported to work pretty well for the hypercalcemia that Dr. Johnson talked about. It can happen. It can help with skin manifestations, as you heard earlier. So I do try that one first because it's just so easy to take. There's no monitoring and there's few side effects. Now, if that is not an option, I think somebody's more sick than that, then I'll jump to an immune suppressing agent. If we're going to treat something urgently and we want a result right away, for instance, if you're presenting with cardiac involvement, brain, or high calcium levels, I'm going to give you something right now that's going to work immediately. And steroids are reliable that way. Prednisone, Solumedrol, if you give it IV, those steroid drugs work very quickly. They suppress the activity of the granulomas, and they even may regress the granulomas so they disappear from the X-rays and such. But as we talked about earlier, if you are maintained on those steroids for any long period of time, I'm sure a lot of you have had side effects of those drugs that you wish you wonder if it wouldn't have been better just to have the sarcoidosis, right? If you're getting all those side effects from the steroids. So I always try to get people down to, depends on your size as to what's the appropriate dose for steroids. If you're a very large person or a little tiny person, the same dose might be just have a bigger effect or a smaller effect. But generally speaking, I'm trying to get people to every other day dosing at no more than 20 milligrams every other day. That's kind of my approach because the side effect profile of that kind of dosing is more favorable. Every other day dosing, if you can tolerate it, allows me to later take you off the medication without withdrawal from the steroids. The symptoms that some of you raised your hands for earlier are less prevalent if you're on every other day dosing because your body has to make its own steroids. And if you take them every day, your body stops doing that. And it takes a while for your body then to recover. The other thing you should know too is is if you're stressed for any reason and you've been on steroids for long periods of time. Maybe you've been told this before. If you get the flu or need surgery or some of these things, your doctor needs to know that you've been on steroids. Even if you just had been on them 6 months ago and stopped, they need to know, because your body can't adjust to stress well, and you'll need to have steroids given to you during that period of time. It's a little bit distracting trying to talk to you now. So what are they saying about it? So the steroids, they're kind of the mainstay of therapy. A lot of people are on those, but I think at lower doses they're tolerable. The risk-benefit ratio is pretty good for steroids as long as you're not on more than that 20 milligrams every other day. You still could have problems over time, but again, you're using it because you've decided this person has something critically wrong. This medic or the sarcoidosis is threatening in some way, and I'm committed to treating. Now, if I can't get people down to that dose and their symptoms, their diseases are managed well with that, we add steroid-sparing agents, and I think the most common one is probably methotrexate. How many people here are either taking or have taken some methotrexate before? And how many of you had symptoms that you think you had relating to that medication? Maybe 20% of you or so. I think that's about right. I think it's a pretty well tolerated drug. Most people that I treat with it do okay with it. They don't like the monitoring part. You got to get the blood checked periodically, this and that. But relative to steroids, I think it's a better tolerated drug. And in combination with steroids, it allows you to use less steroids, less prednisone, so that then the combined effect is that you're not on very much methotrexate, hopefully, and then also on a low dose of steroids. And so a lot of my patients achieve that balance with the combination of prednisone and methotrexate. If that fails, though, then I have to think about other medications. Sometimes you just switch to another class of agent, a second-line therapy, such as azathioprine. Anybody take azathioprine here? One or two. And in Europe, if I had the same survey, it would be one person on methotrexate and the rest would be on azathioprine. So they're kind of equivalent. It's just the doctor's preference, sort of, or what literature they adhere to as to which one they use. In Europe, they tend to use azathioprine for some reason. Leflunomide has been shown, actually Dr. Culver right here conducted a study to show that leflunomide is very effective for patients with pulmonary sarcoidosis, and it can be used alone without steroids, and it still works. So we often use that medication if the methotrexate is not tolerated. And then if those things are failing, that second-line therapy, the steroid-sparing agents aren't working, that's when we start to talk about anti-TNF drugs like infliximab or adalimumab and other agents such as mycophenolate or cyclophosphamide. How many of you have been treated with one or more of these, that class? So you probably had been tried on these other medications and it wasn't quite cutting it, so you had to add another layer. So that's a pretty typical pattern, and I think a lot of you are familiar with this protocol. But there are some special situations that call for, I think, different approaches. For instance, cardiac sarcoidosis is a special condition, very serious condition, and it's been shown, though, that many people with cardiac sarcoidosis, there's some reversibility of the disease. In other words, if you're identified with cardiac sarcoidosis and you're not already on some kind of treatment, it is beneficial. A trial of treatment is often worth doing because many people have an improvement in their heart function. They might have also improvement in the amount of arrhythmias, like abnormal heart rhythms that they have, ranging from heart block, for which you have a pacemaker, to rapid heartbeats like ventricular or atrial tachycardias. Those sometimes get better with the immune therapy. So again, when a person is responding or has cardiac sarcoidosis, they tend to be on therapy for a little longer because you want to make sure that when it's in your heart that you have a long sustained control of the disease. So almost always I put those people without any delay on some steroid-sparing agent because I know they're going to be on treatment for a while. And if I kept them on steroids for a year, I know they would have side effects, and they would not be happy with me as their doctor. I tend to go early to second-line therapy when it's cardiac sarcoidosis. I would also say the same is true of neurosarcoidosis. We don't mess around with that one either. We don't want you to lose brain function and have irreversible brain injury. So I'm quick to adopt the second-line therapy for neurosarcoidosis. And there have been at least anecdotal small reports showing other agents might work if the typical approach with, say, prednisone and methotrexate isn't working well. Mycophenolate has been shown in some small studies to work in those people that don't respond. And Remicade, or the anti-TNF drugs, are effective for central nervous system disease. But it's also, as you heard earlier from Dr. Judson, it also is one of the therapies that might work particularly well for the small fiber neuropathy. How many people of you have the small fiber neuropathy, the pain? And what are you taking for that? Yeah. It's very expensive. And same is true of Remicade. So some of you, others on Remicade. So it's one of those two usually, and they're both really expensive. So we're really looking for a better, less expensive option. And actually, Dr. Culver is involved in a study looking for a new therapeutic option. We don't know; it's not quite ready for prime time yet, but I think it's good to know that we're working towards some new treatments that might be less expensive, and hopefully less expensive. But you want to say a word or two about that? Okay, cool. I'll move on because I'm running out of time. The alarms are going. I feel like some pressure to keep. I think you already heard also from, I won't get into the treatment of lupus pernio, but that's a skin manifestation. You saw the disfiguring. It often does respond about half the time to antibiotics or steroids or methotrexate. But in some cases, you have to move to the third-line agents like infliximab or anti-TNF drugs to manage that disease. I talked about arthritis pain a little bit. In addition to hydroxychloroquine, I think leflunomide is actually particularly good for people that have joint aches and pains. So I use that preferentially more often in people who have sarcoidosis with joint aches and pains, particularly if they failed hydroxychloroquine. And I don't know, do you often use, Dan, 2 drugs in combination like that? I do that too. You might be on both of those agents, for instance, if one's not quite cutting. And there are some other issues that change the way I approach people. If they're already overweight or if they have a diabetes, I would stay away from steroids. I try to get them off on the lowest dose or off of steroids if possible. And that pushes me towards earlier to methotrexate, azathioprine, even anti-TNF drugs, those kind of things. And for kidney disease, how many of you have had some problems with your kidneys? If you have problems with your kidneys, you've got to watch with methotrexate. I don't know if any of you are taking methotrexate. If your kidney function is still okay, it's fine. But if your kidney function is not very good, you have to watch out because methotrexate is cleared by your kidneys. So in that patient population, I often stay away from methotrexate. And if I do use it, I watch them very closely to make sure they're not getting toxicity from the drugs, blood studies, and such. And if you have any questions during this discussion, please go ahead and ask. And then liver disease is a tricky business if a person has liver disease. Sometimes the treatments, even though they're liver toxic, are actually improving the inflammation there, and the liver gets better. Even though it's, methotrexate is a drug that can cause liver inflammation, as is azathioprine. That's actually one of the things we monitor in your blood regularly if you're on those medicines. But if you've got a lot of liver disease from sarcoidosis and it makes it go away, it can improve your liver disease. So you kind of have to figure out, whether the drug is good or bad for you particularly. But in general, I might try to avoid those medications in people with bad liver disease because it can make it worse. The drug itself can make it worse. There's another condition that you may not know that you had or have, is that some people, when their sarcoidosis is active, their white blood count drops. And actually one subgroup of cells in your bloodstream gets particularly low, the CD4 cells. These are special T cells. And they're the ones that help you fight certain infections. So when those get low, it can be a problem. That's kind of why some of you might be on this Bactrim. Are you using Bactrim, some of you, for 3 times a week or something like this? That's why you're on it, because you might be at risk because of the low CD4 cells for certain infections. Okay, it's not to treat anything; it's to avoid infections, right? It's a protection against infection. So some people, when you treat them with steroids and their white count's already low, or you put on methotrexate or one of these other drugs, it might even get lower as you treat them. Sometimes that happens. So we found that actually in those people, a lot of the other usual therapies don't put them at threat for infections. They get too many infections. So we found that the anti-TNF drugs actually work pretty well in these patients. The TNF drugs don't wipe out CD4 cells. It actually promotes their proliferation a little bit, is what we've seen. So we can see white counts go up a little bit on the anti-TNF drug. So there have been a couple patients who didn't tolerate other drugs because of the white count, and we put them on infliximab, and they did better. So specific issues that we talked about at this meeting in the science, on the doctor side of things, at the other meeting, we talked about cardiac manifestations of sarcoidosis. This is still something we're in an evolving area of investigation. We don't have all the answers, but we are much more engaged than we used to be with our friends, the electrophysiologists, to help us manage cardiac sarcoidosis, because heart rhythm problems are one of the biggest issues with heart manifestations. So some of you probably have heart rhythm problems, and any of you have a pacemaker or an ICD. And I think those devices are very helpful for me to manage the sarcoidosis, cardiac sarcoidosis, because again, as I mentioned before, some of the treatments like the steroids, the methotrexate, those kind of things, will have an effect on the number of arrhythmias you have, which are being monitored by this device. And that's how I actually adjust the therapy sometimes. So I find it to be helpful to monitor the heart rhythm in those people that have a serious case of cardiac sarcoidosis. Some people don't need that device because they've been checked by electrocardiograms and further testing. Holter monitors you for a couple days. And if you don't need one of those devices, you don't need one. But if you need one, it is helpful for the management. And so the combination of a cardiologist treating you for the rhythm problems and me, generally speaking, or the sarcoidosis specialist managing the immune suppression, that is a good team there. I think you generally do need to have a colleague in the cardiology side to help manage your sarcoidosis. And then the last thing is, a lot of times people that have cardiac sarcoidosis have chest pain. You know, they end up going to the emergency department sometimes feeling like they're having a heart attack. And they'll get worked up, the whole thing. You know, you get all the tests and the EKG, and you might even go to the cardiac catheterization lab. I don't know if anybody's been through that, but that does happen. And so those patients often do respond to the steroids and those kind of treatments, but I'm finding that some of these patients will respond to nitrates too, or the same medicines they use to open up blood vessels in the setting of ischemic heart disease. So fatigue, I won't get into fatigue because I thought Dr. Judson covered this very well. If you have questions about that, we can discuss it in the panel discussion format. But I'll just mention briefly that sarcoidosis-related, I'm going to just a few novel therapies. Some of you are here because you wanted to hear what's new. There's a few NIH-funded clinical trials that are new approaches to the treatment of sarcoidosis. The first I'll mention is a trial run from Vanderbilt, and that also involves Cleveland, Cincinnati, and Ohio State, just recently joined. This trial basically is based on the premise that sarcoidosis might be an infection, and that by using a combination of antimicrobial agents over a period of about 6 months, you might even cure the disease. So We don't know if this is true or not, but it's an interesting premise, and that study is ongoing. And there's some preliminary data that was published that suggests that it might be very helpful. Nicotine patches, I know somebody asked that question earlier. We're actually running that trial in Columbus with Cleveland Clinic. I don't know if you know this, I probably shouldn't say it, but smokers are protected from sarcoidosis. The prevalence of sarcoidosis is less than smokers. We don't think smoking is good for you, but we think that components of the smoke might have something to do with the suppression of your immune system for sarcoidosis. About time to run out of time yet? Sorry. Okay. So just to follow through on that, the nicotine part has been shown in the laboratory to have immune suppressive activity that we predict would work in people with sarcoidosis, and that's driving that treatment. The other beneficial effect we think it might be the nicotine probably has an effect on fatigue as well. It's a stimulant. So the last thing I would encourage all my patients, once I get their disease under the best control I can get it, I encourage them all. They ask me about this. What should I eat? What should I do? I said, well, I'm not aware of a confirmed sarcoidosis diet, but I think a good diet with the green stuff and the fruits and vegetables, a healthy diet is probably a wise thing to do. And I try to encourage them to exercise as much as they can. If you have arthritis or whatever, I try to get them into a swimming pool, do water aerobics. Everybody should be exercising as much as they possibly can, in my opinion. Because I think, I would rather personally, I'm a terrible patient. I try to avoid medications. If I can get by with going to the gym, and if that was if I could eat a better diet and feel better, I would go that route, and I think most of you would probably agree with me that it's better to treat the illness with these kind of healthy habits than to actually take another pill. So I'll leave you with that. I'm hoping that this is not the kind of research that gets funded by the government or other industries, but I'm interested in seeing the results of studies where people exercise more or eat better. So I'll leave you with that, and I know we're running behind, so I'll let whoever's up next